And welcome. Good to have you with us. It's Easter week. It's Passover week. It's holidays.
Yes.
And we do a webinar. Timing is everything. So thanks. Good to have you with us. We're going to talk about something that's been near and dear to my heart, Danielle's heart,
Yes.
our clients' hearts, because it's one of those things where, you talk about it and you think it's routine. And then anytime anybody visits our office, which we had last week,
Yep.
somebody started videoing my doing an examination and asked our permission. We gave a study club meeting in California on the full examination. We had a couple clients who said, since we started doing the full examination, I've had people say, this is the best examination I've ever had. And I've never heard that in my whole 27-year career, is what this doctor said. It's that important. And so we said, okay, we do these seminars quarterly. You probably know we're going to ask you to join the IDS, but we want to make sure that before we ask you to join the IDS, that we actually give you something that's really of substance. So we decided this would be it. And we decided to call it How to Become a Big Case Provider, because you know what? By doing this examination, we became big case providers. We did.
This is one of our building blocks to creating the IDS, was the examination. And a lot of what we do, a lot of our building blocks, we didn't even know were very different than other people did them until we started to go into these offices and see what they do, or them come here and noticeably say, wow, we've never done things like that. And I've been in many offices all around the country, and nobody does examinations like this. So one of the big things we do is teach examinations like this, because it does help the patient. It does impress and increase your referrals, not only to the general dentist, but the patients that leave here like, wow, this was amazing. This was just so different. Patients like to know that you're not just looking in that one area, because the one thing we all hate to hear is, well, why didn't you say that before? Why didn't you catch that before? So we want to give that full examination before we start on anything.
Yeah, and I think if you're on this and you're not doing the full examination on everybody, do it. Just do it. Unless you do the full examination on everybody, you won't know who the big cases are and who they aren't. We're going to show you a case today who said, I don't have any money. Started off that way.
Yep. Yes.
And you're going to see how that case became one that patient
Right.
is spending a lot of money with us.
Right.
And it wasn't because we sold it. In fact, if anything, I probably undersold it. In fact, I didn't sell it at all. You become comfortable. I did I?
I sold it.
Oh, you sold it.
So kidding.
That's why. The idea is make sure you hire Danielle to work in your office. And there's no problem. You don't have to sell anything. She'll sell it all. There are things that happen when you assume that somebody does something, or the general dentist refers for a free gingival graft. You say, okay, I'll examine you on teeth numbers 24 and 25 and schedule the free gingival graft. There's something that happens when you don't do that. I'm not saying don't do the graft, of course, but there's a certain amount of discovery that occurs, not just on your side, patient's side.
Right. So
when a patient says, I've never had an exam like that before, what do you think that patient is seeing, feeling, hearing, wanting? And that's, we're going to talk about a little bit about that tonight. So should I go on with any other?
But we'll say yesterday we did a new patient examination together, and we don't get a whole lot of referral patients anymore. We're proud to say we get a lot of the patients from off the streets, but we did have a referred patient yesterday. I don't know if you remember the guy yesterday that we had together. He came from a referred office for an isolated, just one little thing. Just look at this one little thing, which you guys are all used to this. Just look at this one little thing and that's it. And because we're not used to that, remember the lesion?
Yeah.
Okay.
The lesion, that's right.
When he came in, he just was like, oh, well, we'll just take a look at this one area. And at first it's kind of, maybe we'll just look at this one area, because it comes from a good dentist, a good source. And we have a good relationship with this dentist. kind of entertain the idea of just looking at this lesion.
I broke my rule.
You broke it. But you know what? We did a full comprehensive examination, and we had to do 2 IP with DV.
Yeah.
We were doing a
That's
soft tissue.
perioscopy. Yeah.
So
And a soft tissue graft.
if we would have just looked at just that area and said, nope, looks good, it's not cancer, don't worry about it, that type of thing, we would have done him a disservice by not treating all this built up calculus and everything that was in there. We would have missed it.
Yeah. So anyway, that's the deal. So I broke my own rule and found out I should never break my own rule again. Is that what
you
that what we
train
figured
your
out
assistants
here?
right, and they won't let you forget
Exactly
anything.
right. All right, so let's go back to the screen. So here's what we're going to talk about. We're going to talk about what patients are looking for when they're seeking a major change in their dental condition. We'll talk about an examination sequence that elevates you. We've already given you that hint. And applications of communication flow principles, communication flow principles, and differentiate you and your staff from anyone else. People are so impressed with my staff. A lot of them have only had high school educations. They're so impressed with my staff. They can treat and plan. They can treat and plan dentistry. They can. So if they can treat and plan, yeah, okay. I know we went to school for such a long period of time. They can treat and plan. And we give them a chance to treat and plan. No, we don't tell them. They're not making all the diagnosis and treatment planning. They have to leave something to me. But they sure do know what's going on. And by doing that, I spend less time in the operatory because patients here for a 2-hour experience, a half hour of that is mine. That's about it. One thing we have to make sure that we know of is that when a patient comes in, they want something. And part of the reason for the examination is to not only examine them, but to find out what they want. We're so interested in what? The what is the implant, the what is the graft, the what is the bone graft, the what is the sinus, the whatever. They don't care. They want teeth. So what's the want? They want to smile, they want to chew, they want to be free of pain, and they want their mouths to smell good. That's the main wants. That's it. I defy you to give me, I suppose you could talk about periosystemic, but people don't come into us for periosystemic. We might be able to talk to them about periosystemic. That's not why they're here. All right, so what leads to the want, and that's the full examination. And so if we can match the want with the what, that's what we do. Now, the next slide I'm going to show you, you're going to say, stop giving me a whole bunch of words. I'm going to give you a whole bunch of words because you're going to see the whole examination on this one slide. So if you want to do a screen capture, the one slide to do the screen capture on is this, because this is the entire, well, no, I'm sorry, I didn't give you the whole thing. I'm only giving you a column. Sorry, not yet. I will give you the whole thing. So I believe there are 26 points in the examination. The first one is pH level. Have you ever used pH paper to take a look at a patient? Why would you use pH paper? Because patients don't just have periodontitis, they have caries. And they want to know why they have caries, because they're concerned. And not every one of them eats sugar. But a lot of them are on a lot of medications. But they want explanations as to why their crowns have failed. And particularly if you're working in a referral practice, then you actually are covering for your restorative dentist by telling the patient what the pH is. So if the patient is blaming the dentist because the crown failed 2 or 3, 4 years later, and you find out that the pH of their saliva is 5.5, do you think that would help the general dentist? Hey, it wasn't your dentist's fault. Your mouth is bathed in acid. And at 5.5, you're just demineralizing all of the tooth structure. That's what you're doing. That's you. So important. pH paper, go find some pH paper on Amazon. It costs $10. Okay, next head and neck examination. Next is intraoral. And essentially, Danielle's reading this off to me.
Yep.
Okay, so she's saying something, I report back to her. She says something again, I report back to her. It's checklist fashion where she and I are communicating to each other in front of the patient. trying to put it in patient-friendly words,
Right.
by the way. Sometimes fremitus, she might say fremitus, and I might say, when she bites down, teeth numbers 4 and 5 are moving. I might say it that way. And so we just go by checklist.
Right.
Angles class, fremitus, overbite. By the way, I do overbite in percentages, okay? 10% overbite, 20% overbite, 30% overbite, 40% overbite. This vertical overlap. Overjet is done in millimeters, okay? Then this crossbite, bruxism.
Yeah, I'll say, are they a grinder, clincher?
Yeah.
Because they don't know what bruxism is.
In fact, why do you do it? Why am I reading off the stuff that you do?
The next one, well, how severe is the wear? Because I want the patient to hear there's wear everywhere, because the patient, like yesterday, says, well, she eats a lot of nuts. That's why. No, this is not because she eats a lot of nuts. This is because there's wear all over these teeth. Effraction, any erosion, any noises or restrictions in the jaw joints. How far can Miss Jones open up? What's the Malapati score?
Malapati score is one you'll get from the anesthesiologist. Take a look up Malapati on the internet. You'll find diagrams of Malapati. It's how far the throat is open.
I'll ask how the roof of the mouth is. How's the palatal vault? And just in case, like, we're not going to plan dentures, or we'll know that's a bad idea to do dentures. How firm is the gum tissue? And that way they know that we're talking about the gum tissue. Then we'll go to the chart, and we will chart missing teeth. We will chart the pocket depths. I'll ask about mobility. I'll say, are there any teeth that are loose or moving around for recession, gum recession? Any bleeding, calculus, plaque. And then for restorative, I'll say, is there any caries? And he'll want to do a full caries examination.
And I got to tell you, for those of you periodontists, and that's everybody who is listening to this, whether live or later on, almost everybody's a periodontist. Do a restorative examination. Make sure you're doing a full restorative examination. You're all trained. Everybody's been trained to do restorative. And it's not just there's caries on tooth number 3M. Come up with what the restoration might be. I think it's going to be number 3 MOL. You can even start by doing that, or you can say you may need to build up a crown, and your assistants can get so good they'll be able to know what the referral sources fees are for buildups and crowns. And so you have the opportunity of giving the patient a full fee if you and the restorative dentist agree. In our situation, we don't have to restorative dentist agree. Both Dr. Matt Sheldon and Dr. Michelle Furtado love the fact that I'm doing the examination because they don't have to.
Yes.
And of course, I'm doing the entire restorative treatment plan, which is the goal for every one of you who want to become a director of dentistry. Okay. Not everybody does, but if you do, that's the goal. So restorative is really, really, really important.
I'll ask him what the diagnosis is. So he'll go over what that is.
And I'll give it. I'll say, moderate, generalized moderate periodontitis, or if you want to put it into World Workshop 2017 classification, you can do it that way. However you'd like to do it. You probably ought to do it in World Workshop way, because that is becoming the standard.
Right. I'll ask him if he wants to do an oral DNA test. And I'll say, what are the problems to note? And he'll go over what each one of the problems are. Missing teeth, mobility, whatever it is, periodontal disease, and then what are the treatment plan options? So one, they could do full extractions and dentures, 2 full extractions, and do a fixed end prosthetic, snap denture, single implant, if bridge, crown, whatever it is. Give all the options, because sometimes we send them to their dentist for an option that they want to consult about a bridge. Whatever it is. So we can give them all their options, because that's what patients love. They want to know, they don't want to be told that this is what we're going to do right here, because they kind of feel trapped in that. Even if the option is to do nothing, even if the option is to do a full denture, we know that those aren't good options. And we'll say, I wouldn't do it, but you could do this. I want to explain to them exactly what it is that they're looking at with these options.
This is the one you should do your screen capture on. This is the exam right here. Okay. And then the most important words in the case note are not words, they're 2 letters. NV, next visit.
That's right.
Always put your next visit in every time you see a patient, every time you see a patient for anything, not just the examination. What is the next visit going to be? Rather than searching the notes,
Yes.
you know, right at that current time, you just
Yes.
completed a particular procedure, you know what the next visit is going to be. Put it there. It's going to save your staff so much time.
Tons of time. Absolutely tons of it. And if there's a sequence of 4 next visits, we do next visit 1, next visit 2, next visit 3, next visit 4. And we copy and paste that and carry it over to every single chart note that we do. Of course, deleting the one that we've already done so that we never lose track of what we did. Because before doing this, we had to search back and search back and search back and search back. It would take so much time to go back and find out what phase 2 was, if we were doing a night guard at the end, or if they were going to do a reeval on the other side of the mouth. Just put it all right there. You know, after you finish the extraction, implant restorations, whatever all that is, then the next visit 4 is reevaluation for number 15, just so we know what the next phase is going to be.
Okay, so let's go. I'll take a little break. We'll get back on the screen for a second. Okay, so now we're going to go not just new patient examination. We want to show you the entire patient flow that happens in our office. A patient flow, or any flow, is a communication flow. It's communication between the patient and our staff, and then our staff to the doctor, and our doctor back to the staff,
Right.
or our doctor back to the patient. And there's always a flow sequence that occurs. Okay, it's just like water going down a hill, or for water flowing down a river. There's a continuous sequence that if you repeat more and more and more, you find out that you get more information from the patient. Patient feels this is the right office because they've never seen such structure happening, and that's how you get big cases. I'm not saying you don't get small cases. I mean, we're a primary care practice. In our office, we've had some kids in for prophies this week,
Right.
you know, but that's basically we're an adult major reconstructive practice where there's a periodontist and a restorative dentist here, and there is me. I guess, doing the examinations. So I've said this before, but I haven't said it recently. If you think you need 8 or 10 good referral sources in order to be able to make a perio practice work, we have two periodontists, one restorative dentist. We're doing very well. So forget those paradigms out there. I think there are lots of different paradigms that work. And this one's working very well for us. I think we could probably use another restorative dentist.
Yeah.
True. But you know, Matthew's swamped, but okay, and he's not so swamped that we're not seeing good patients. So and we're not seeing them, we are seeing them on a rather timely basis. So let's go back to the screen. So the first thing we do is the intake call occurs. So this one on this call, this is Jill taking this call, is that right?
Mhm.
So and no, Amy took the call, Jill made the note.
That's right.
Okay, so Amy took the call, and it's an internet referral. Yes, most of our referrals are internet referrals, magazine referrals, other patient referrals. That's where referrals come
Right.
from. And yes, we have a group of patients, a group of dentists who do refer to us, but it is in the lower category rather than the higher category, higher percentage category. And I'm very happy that way. And if you do it, you could be very happy that way too. Imagine being able to control everything under your roof. Imagine not having to satisfy a doctor and a patient.
Very nice.
You knew me the other way.
Yes.
I'm probably
yes.
just as bad now as
We
I
don't
was
want to
then.
get started right now on that.
Okay,
We have
yeah.
to focus.
Yeah, thanks. Okay, so he went to his ENT. So this is what Amy writes down. The patient says he went to his ENT and was told that there was an infection due to his teeth.
Yep.
His dentist passed away 5 years ago, and he hasn't been to the dentist since. Okay, so that's the way it starts. Now, what does Amy do, or Jill do? This note comes up to my desk, and along with the patient's phone number, and sometime before the patient comes in to the office, I'm calling that patient. And when I call that patient, I say, hello, so-and-so, I understand you went to your ear, nose, and throat specialist, and he or she said that there was an infection due to your teeth. So what does the patient know? Number one, the doctor's called. That never happens.
Right.
Before the visit, absolutely never happens. And then number two, Amy's already communicated with me as to what's going on. So now he knows communication is going on in the office.
Yes.
It's rare. It's rare in medicine. It's rare in dentistry. So all of a sudden, something is different in this patient's mind before he's ever walked in. Okay, so that's the doctor call. So in this case, there was no doctor call. I didn't make a doctor call. I don't know why, but I didn't. I was lazy, whatever it was. Okay, so now Danielle sees, and these are Danielle's notes. So this is, I'll let you, what do I have to talk about for you?
So really, I just put what I've done. I with this patient, it's been 5 years. He hasn't seen a dentist. So I do a full series of x-rays. We are a periodontal office. We want to make sure that, you know, he doesn't have the bone loss or the issues there.
I don't care. You can be any office. You can be a restorative dentist office. You can be a prosthodontist office. You can be an oral surgery office.
And we hate to get the ones that were sent over from other offices because they're not good, but we do a full series. We do a CAT scan. We do a CAT scan for obvious reasons. It's also very impressive with the patients. And we take the photos. We take the different photos. So one, mostly for me, so that as I'm taking these pictures and it's on the big screen right in front of them, in front of their chair, they can get a close-up view of what's going on inside their mouth. Because for years, patients usually convince themselves it's not that bad. They know it is, but when they see it up on that big screen, it really, really comes to surface. So he told me his last cleaning was approximately 15 years ago. He did have some major recession going on the lower teeth. 21 was very, very loose. He was diagnosed with periodontal disease before, never kept up with his cleanings, because he said at that time, he just said it just really didn't bother him too much. But we all know periodontal disease doesn't hurt. And so we go through that education. Patient went to another dentist and he recommended extracting all the teeth, and patient did not want to do that. So he came to us because he didn't want to extract all of his teeth. And so here's what I did, the full series of x-rays and the pictures. And so with everything that you just saw with my notes, going to the pictures and him seeing what's really going on, looking at the recession, looking at the caries all on the upper, it really gives the patient a really big idea of what is going on.
So you can just see a picture like that. The patient starts smiling and starts to see what's going on. Okay.
Yep.
You know, a lot of people like that aren't going to look in their mouths. And now it's up on a 40-inch screen. Think that might make a difference?
And you know, another thing that he said was he stopped brushing his teeth about 5 years ago. Why? Because the only time his teeth hurts is when he brushes them. Some of it had to do with he had so much recession that the plaque and calculus was creating that barrier, so it didn't hurt as much, and they were loose. So when he brushed them, he was afraid he was going to lose them. So he was not brushing his teeth at all.
No, and you know, he said rock bottom. Yeah. I mean, how many physicians say go to a dentist?
Right.
You know, so fine. He had rock bottom, and now we're the next to bottom.
Right.
Okay, we take a CT scan too. And we take a CT scan on every single patient. Oh, we won't do it on a kid. Kids going through ortho, we will.
Yeah.
I want to know how thin that bone is. Orthodontist wants to know. Actually, the orthodontist we work with wants to know how thin that bone is too, which is kind of neat. Yeah. You know, we're moving teeth in 3 dimensions, just like we put implants in 3 dimensions. Orthodontists need to know this information. So we do this in every single patient, and there's obvious reasons why we do it. You know, we're talking about implants. We want, you can see apical abscesses a heck of a lot better on a CT scan. You'll miss them on PAs. I missed a lot of PAs. Right,
and also another one of his concern was ENT issues, his roots and the sinuses. His sinuses being a cause of some of this discomfort he was having. So this is also a good tool for that reason.
Yeah. Okay, so then I'm doing the examination, and Danielle's making more notes.
Right.
Danielle keeps on making notes.
Lots and lots of notes.
Danielle's fingers are going constantly as we're talking.
Right.
Her fingers don't stop. If there's any assistant who's watching this, get that idea. There is no reason to sit there. Every note is important. Everything the patient
Right.
says is important. We can go back and reference these notes later on, particularly when we're
Right.
getting into a conversation with the patient
Uh-huh.
about why they need what they need, So just keep it going. Besides that, it's a medical legal document. So there's more and more
Right.
notes.
Well, my job is to help the patient accept treatment to improve his life, his smile, his chewing capabilities. That's my job. If I don't have good notes, I see a lot of patients every single day. If I have him coming back in a few weeks to talk to him because he hasn't accepted yet, I'm not going to remember this guy. The pictures hardly make me remember the guy anymore. I'm getting old. I don't remember this stuff. So I have to read all these
I'm
notes
glad
to
to
go,
hear that from
oh,
you.
I remember this guy. I need all these details because I need to remind him of why he came in and why he needs what he needs.
All right. So we don't have to go through all the details here. I just want you to
All
see
my notes.
how much.
Right.
Okay.
So long story short, this guy had some issues. He was a smoker. He quit smoking and he had this addiction of needing to have something in his mouth. That something when he would stick Altoids in his gums between his teeth and his cheek because it was something that helped him in some way. Nicorette, sugar-free gum. He didn't do the Nicorette anymore because it made him sick. But he was doing sugar-free gum and he was doing Altoids. And he was doing that every day. And he was a high orange juice drinker. In his mind, he doesn't eat sugar. He has a really good diet. But he doesn't think about these pieces that, of course, I'm making notes because we need to have him understand what actually he's doing to his mouth.
Then he asked me if his sick feeling could be coming from his teeth. And I said, I can't say for sure. But there are a lot of infections. I was able to show him some sinus membrane inflammation, as you remember the CT scan, a little bit on the upper left side. But that certainly wasn't what would be responsible for sinusitis. Not at all. Okay. So we talked about what we saw. And then we went through the checklist just the way we just talked about. Okay. So we'll go through this quickly. We don't have to detail. But now with the CT scan, I can start to show some things. Like I can show the relationship between the lower incisors and the upper incisors and how it might be difficult to restore incisors with the position of the lowers the way they are. You see how the lowers are in a strange position, particularly in the right screen. And so that's responsible for some flaring on the uppers. I can explain it that way. I can also explain it this way. Because like you can see how deep the overbite is and how the lower incisor is acting as a wedge against the upper incisor. So I can show that. We can also show how little bone there is for that lower incisor, but there's still bone support, so I'm not really worried about that. So we just go through the entire checklist just the way we did before. I understand this takes a half an hour.
Yeah.
Not the examination. The amount of time I'm in the operatory is a half an hour. Now, will I get into an extended discussion if I have time? Yes, I will. That's all I do. Does our acceptance rate improve as a result of my being there? Probably not. We can get this done in a half an hour. But the only reason we can get it done in a half an hour is because the assistant is trained on everything else. And the assistant has begun the examination with a 40-minute intake before I ever walk into the operatory, taking all the x-rays, getting all the details, putting down all the notes, doing an interview, and the interview should be structured as well. So that by the time the patient comes in, by the time I've walked to the operatory, Danielle's gotten everything. She's gotten the x-rays. She's been able to review the x-rays of the patient, saying what I possibly will say, something like that, right?
Yeah.
I don't know what you say. I've never seen you in it.
Usually I just say what possible options are going to be because I want to prepare them for the worst. And that way, if it's not that bad, it sounds like a great deal and, but may as well do it before it gets worse. So, I don't use scare tactics, but I do want to prepare them so they don't have shutdown. And give them the models to hold and show them pictures of stuff. And so they understand what's really going on. I don't diagnose, but I point out the obvious to them. And obvious is in pictures. Obvious is in x-rays. You can see black decay. You can see where the bone level is supposed to be and where the bone level is, that kind of stuff. You can show patients stuff like that.
By the way, we didn't, we missed the briefing step. So when Danielle's done that 40 minutes, then she's calling me. I happen to be upstairs and she's downstairs.
Yeah.
So she'll call me, give me a briefing on what occurred in the operatory, so I'm prepared.
Right.
And that way, when I walk into the operatory, I can already recite
Right.
some of the things that Danielle has already told me. So that moves the examination along. And again, it's a communication exercise. Communication is flowing from the patient to Danielle, to me, and then I'm flowing it back to the patient when I walk into the operatory. Okay, calculus heavy, plaque heavy. Okay, so we do our periodontal probing examination. Nothing strange about that. But now we've used this software. This is the Anatomize software, and you can see some neat things with that. And if all I do is just show the software, just show this, I've never seen that anyplace before.
Yes.
I paid $5,000 for the Anatomize software. That's what I pay. Probably, I think it's a maintenance fee of $700 a year. It's it's what you do to get big cases, is what you do. So now, knowing that, or with the possibility that we're going to take out the teeth, what do? I start putting implants in place. I may do that before I even do the probing examination, by the way. And I start doing this, patient. And what do you say when I'm doing it? I don't know what you say.
I said,
When I'm
look,
doing this?
he's doing surgery right now in your mouth.
Oh, that's right.
So that way they're like, oh, wow, that's pretty cool. That's neat. And then he starts talking about the bone availability and what the patient does have and what we can work with. And so it kind of gives them that hope that there's something we can be doing here.
And I'm looking at that the same way. So, I start repositioning them and we start to look at where the implants are. And you can see how the implants fit in the bone. Boy, look at how you've got great bone here. Look at the bone. That's your implant. Look how wide your bone is. You've got fabulous bone. You'll never need a bone graft for this. So now the hope is there. Yeah, there is the opportunity for implants. I won't go into detail on this. You all get the idea. Okay. I want to go over something else. Let's look at the models for a second, Danielle, because you show the models too.
Yeah, and before he even gets into the room, because I can see what's going on, it's obvious to all of us that there's not much that he's going to be able to do with a lot of these teeth. So just in case, there are options of full extractions, implants, fixed and prosthetics, full dentures, or whatever it is. I do feel in his case, when I'm looking at him, that crown and bridge is not going to be an option. He's got calculus and plaque everywhere. He's got severe decay everywhere. I'm going to give him all the information. So when I'm talking to him and I'm saying, okay, listen, Rob, if Dr. Sheldon may say that there's really not much we can do for these teeth. The number one goal that we have is to save these teeth. He's a periodontist. He loves to save teeth. The best option is to keep your teeth if you can. So that's going to be our number one goal. But if we can't save these teeth, you have to know what it is that your options are going to be. You can either go with a full denture. So we can extract all the teeth. We can give you this denture. This denture looks nice when you put it in. You have nice teeth. It's going to look good. However, the problem that you usually have with dentures is you lose the taste because you have this full palate that's being taken up in there. It's big, it's bulky, it feels big and bulky. It's removable, and a lot of people don't like that. And I tell him, because it's true, he's like 52 years old. You don't want this at 52 years old. It's an option, and we're going to give it to you, but you don't want this at 52 years old. I'll show him what you would want at your age is something that is a fixed in implant supported prosthetic. So if we can't save your teeth, we're going to take everything out. We'll put in these implants into your bone. They fit into the bone. And then we screw in this prosthetic. It goes right onto the implants. It's fixed in. It doesn't come out. And guess what? There's nothing on your palate. It's very small. It's like this. It's very tiny compared to having the denture, which is like this. Big, big difference. So I'll say to him, at your age, with this, fix it in, never comes out. Nobody knows. You even forget after a certain amount of time. You can eat whatever you want with this. You can taste what you want with this. So it doesn't change your life. If anything, for this guy, it's going to improve your life for this, cosmetically, functionally, everything for him, and health-wise as well. So I do go over, it is important that he, does look at those. So I show him all this stuff. I'll also show him that if he doesn't want to do, if he doesn't want to go all that way, we can do some partials. Save what we can save, clean up what we can clean up, because the most important thing is health. Get out the bad teeth, clean it up with a periscope, and have a partial and keep those teeth for as long as you can. I don't know, it's an option. So if that's what you want, then fine, that's what you have. Again, go over, but don't expect to be eating steaks and such like that with this. It is what it is, and I'll go over all that with them as well. So I take some time to go over that. He holds them in his hand, he looks at it, he can see the difference. So I do that before Dr. Sheldon comes in.
Yeah. Okay, so here's what I said. I said, I'm not ready to treat you at all. Maybe I gotta go off screen. I think it would have gone.
Yes.
I think we'll go back on screen. I'm not ready to treat you. And talk about solid bite. I don't talk about anything. So you're eating sugar. Got plaque all over your teeth. Said, I'd be doing you a disservice. I will not help you if all I do is do dentistry. So, any dentistry that I do, anything we do, the patient can make that dentistry fail. And right now, the way your mouth is, no matter what I do, it's going to fail. So certain things that you need to do. And essentially, I said, we need some oral hygiene visits. I need you to demonstrate to me, number one, you can get off the sugar, and number two, that you'll brush your teeth, you'll take care of your teeth. So I'm going to set up 3 oral hygiene visits with Danielle so that you can do this. And if we can pass that step, then I can talk to you about some dentistry that we might be able to do.
Yeah. And he didn't say, okay. They never say, okay. Because obviously there's a disconnect. People just don't brush their teeth because they don't brush their teeth. There's a reason. So for Rob, who's actually a very smart guy, he's got his own business. He does very well. He said, well, the only reason why I don't brush my teeth is because it hurts when I brush my teeth, and because I get nauseated. I get nauseated feeling when I brush my teeth. So that's why I don't brush my teeth. So then Dr. Sheldon has to explain, we got to get past that. You can't live like this. He shows him the picture, shows him all that. He even shows him with a scaler, a chunk of his plaque, and say, you can't do that. You're talking about having an infection. He shows them the roots that are up into the sinus. You're complaining about this, but you're not understanding. You're creating that environment in there. We've got to get that out. So it's trying to get him to understand. We understand it's making you sick. We understand it hurts. And he goes over all those reasons.
And it's never that you're a bad boy.
Mm-hmm. Exactly. Because he doesn't know. The orange juice he drinks, a gallon of orange juice, like every day he drank. Yeah. To him, it's vitamin C. It's orange juice. It's good for you. So we have to go over, well, no, it's actually loaded with sugar. The Altoids and the sugar-free gum. He thought he was being great by having Altoids every day and sugarless gum every day. No, it's not. So it's just, patients just don't quite understand that. So it's dissecting, what have you had to eat in the last 24 hours? What are the things of sugar that you have? And when they start saying this, you're like, oh my gosh. And you have to tell them we can't do that. So we spent a lot of time with this guy going over that. And after he explained it, the patient said, okay, well, let's start. And one of the big reasons why that was good for this patient was because we had to do baby steps with him, because since he wasn't quite yet even understanding the concept of having to brush his teeth, he wasn't going to understand the concept of doing anything with these teeth at all. He would have totally not accepted, left, and never came back again. So we knew with him, we had to do these baby steps. So it was oral hygiene, $25, come in for each one, $25, just come in. And I sat down with him and went over the brushing, the flossing, the proxy brushes, the whole thing with him, to get him to go home and come back in a week and bring me this stuff back so we can do it again.
And I scheduled him for 3 visits.
Mm-hmm.
Danielle comes in after the first visit. She's so excited.
He did amazing. He did amazing. And he was so proud of himself. Oh my goodness, he was so proud of himself. But that guy did not have a lick of plaque on there. It was so shiny and clean. And he was showing me what he was doing. And he was asking where he could buy some of the stuff. He hasn't brushed his teeth in 5 years. He was proud. However, he did say they're hurting, they're hurting now because he doesn't have that barrier between the roots that are exposed and his saliva. But yes, it was. So I stopped it right there and said, okay, your next visit is for Dr. Allen to see you. He's going to be so proud. Keep doing what you're doing. Good job. He brought his wife with him. His wife, he brushes like 5 times a day. She was very proud of him. And so he felt accomplishment. He was like, yes, I can do this. This is good. It's working. So yes, that was our first step with him.
Yeah, so that's good. So now Danielle calls me into the room. Now, I didn't know he had any money. It certainly doesn't look like he has any money. And he certainly said he didn't want to spend any money. I mean, that was what he said right off the bat.
Yes.
So
That
so
was,
all right, those the oral
Right.
hygiene visits. Okay, so we schedule those. Then I dictate my letter. And
Right.
by the way, I dictate the letter right in front of the patient.
right.
Okay, so and essentially I'm dictating the story of the patient. Now, if we're a referral source, those letters go out to the referral sources. If it's what went on in the operatory, I want to dictate a note of what went on in the operatory. And I often want to describe it in the patient's words. So when I'm dictating into my phone, which is transcribed and goes up to my daughter who types it up, essentially I'm giving the story. And when I get all done, I ask the patient, did I get it right? I also asked Danielle, did I get it right? So they've heard me do that. Okay, is that a little bit different? Yeah, for some of us it is.
Yeah.
Okay. So you can see some of the things I've written. It's not that important. It's really the story.
His notes are long, just like mine.
My recommendation would be extraction of the upper teeth and replacement with a denture for now, perhaps implants later on. I even said that. Okay.
And the reason why you did say that was because this was very overwhelming to him. This was all so new. And you can tell what talking to him, he was overwhelmed and it was just too much for him. So we had to go in baby steps. I did talk to him about the fixed and prosthetic and implants. I did say from day one, that's what you should be doing. But because I could tell that he was just kind of backing away, you can always do implants later. The important part right now is to get the bad teeth out, get healthy, and then we can do implants later if you want to.
Okay. And I gave him a chance to save his lower teeth because many of them can be saved. So plaque control visits, and I sent a letter to the ear, nose, and throat doctor. And by the way, I want to send a letter to any doctor who's involved in any way. It's great advertising. It really is. Okay, so this is Danielle. She's gone through this, decided ENT, she's put on a Z-Pack for the sinus infection. His wife comes. His wife said he's committed to this. All of a sudden, we've got a change in the patient's attitude.
He's replaced his Altoids with his Theraments. He is doing good. He's doing amazing.
So there we go. So we do a second examination. And now he feels the reason the teeth are decaying on one side but not the other is he always keeps the Altoid mids on one side, on the left side, not on the right side. It makes a lot of sense.
It did make sense, yeah.
Okay, so he's participating in the discussion. He's been given an opportunity. And now he's been in the office for what? Probably a total of 4 hours? Not that one visit, but I'm talking about the total number of visits. 4 hours before we get around to talking about what the treatment plan is, other than that, then it's going to cost $25 for 3 visits to learn how to brush and floss your teeth. So then I'm coming all sorts of different possibilities. But the first thing is I want to save the lower teeth. So let's do some root planing on the lower arch. Okay, then extract the upper teeth. Extract number 20, which was non-restorable, and do a temporary overdenture on the upper arch and a temporary removal partial denture on the upper arch and partial denture on the lower arch. I'm even giving him a chance to keep some of the teeth, and we'll just do endo on the teeth, and we'll put locator attachments in the teeth. Now they may decay, but because we know he's prone, Carrie's prone, but hopefully we've gotten rid of the etiology of that. But that's the first recommendation. And so I'm saying we'll do locator attachments within the numbers 6, 8, 9, 11. Do I know those? And but that would be a reevaluation after we've done the root planing and after the patient has had
Right,
some successes with dental
right.
treatment.
And no toothaches, right?
Yeah. After discussing the case, the patient said he may do upper solid bite rather than the upper denture.
Because in that discussion, he was telling him, we don't know how long this is going to last. You know, it would be a loss of your investment if it doesn't, because we're working with natural teeth that are not doing very well, because he kept saying he doesn't want to spend the money. He doesn't want to spend the money on implants. He didn't want to do that much. He had the money, but he worked very hard to save that money so he and his wife would have some financial freedom. They're both still working, but they own their own business and they were just looking to, take it easy. So he just didn't want to spend that money. So when we were talking about implants in the beginning, he's like, I just don't want to spend that kind of money. He was asking about denture, he was asking about saving the teeth, just doing some partials. And he was trying to find ways to save money. But as we're discussing this to him and we're saying, yes, we can do that. However, if you're looking for an investment, this is not an investment. You could lose all your money by doing that. We'll do what you want to do, but we wouldn't recommend, would not recommend it. We probably wouldn't do it. But this, we have to let you know all these. And so he's thinking about it going, well, I don't want to waste my money. So he's taking this information with him and he's stewing on it. Plus he still has some pain going on in his mouth. He still has some aches going on in his mouth. So this is all going on.
So then we just continue. And that's how he accepts treatment. Did he pay for it?
Well, when he came in, he did accept treatment to do the lower 2IP with DV with our periscope. And he was going to just do nothing on the upper and just see how it goes. He wanted to put his investment in the lower because he knew that those we could save for a long period of time because those didn't have the decay. It just had the periodontal disease that we knew we could take care of with the periscope. So that was it. He's like, let's just clean up the lowers. Let's just wait on the uppers for right now. I just want to do a little bit of time. Fine. So we did that. And I said, it's fine. You can go however the speed that you want to go. That's fine. So when he left and came back for his root planing 3 weeks later, when he came back for his root planing, I went and I checked on him. How you doing? He's like, well, I'm actually still having this, issue with my sinuses. My teeth on the upper are bothering me. They're hurting. And he was saying, I don't know what to do. And I said, well, Rob, you know what you have to do. You have to do something about those. You're either going to keep having this pain, this is going to keep going, or you're going to just make the decision that you don't have to do this anymore. So I took him back into the room after he got finished with his root planing on the lower, and I showed him the denture again and the prosthetic again. I said, you have to choose one of these. In order for you to feel better, you have to get those teeth out, because every single one of them you couldn't save those teeth. They were decayed, they were breaking, they were shiny and clean, but they were just not good teeth. So because I feel like because we weren't pushing it in the beginning and because he still had this pain going on, he knew he had to do something. And that was the day that he said, I just have to do it. I have to do it. And I do not want to wear that denture, because the other thing for him, and all patients are different. I always tell people, staff members who are doing new patients and doing financials, you always need to find out what that emotional pain point is. And for this patient, believe it or not, when it came down to it, it wasn't pain and it wasn't money at that time. It was that he ate peanuts every single day. And he was afraid with the fixed and prosthetic that had a 3-week kind of soft diet, he couldn't eat his peanuts. He couldn't fathom not having his peanuts every single day. So he actually went to the fixed and prosthetic, final fixed and prosthetic, but he wanted to wear a denture during his 3 months healing so he could eat peanuts if he wanted to eat peanuts. And that was it. That was it. So when I kept asking why, how come you don't want to do the implant? I don't understand why you don't want to do the implants if you have the money. And he goes, I don't think I can go a day without eating peanuts. I'm like, peanuts? We're talking about peanuts here, but you have to ask. You have to find out what that is for the patients, and we did. So he accepted. He paid, and he's having a surgery next week, I think it is.
Well, and that's what training is all about. That's the whole idea of training. Did I do that? No. Did I train Danielle at one time? Yeah. Did Danielle then train Jennifer and Jill and Laura and Joy? Yeah, because we have 5 people in our office and probably a 6th who can do all of those
Yes.
things. And I'm spending a half an hour at the examination, and of course, I went in for the reevaluation to cheer and say, "Wow, Rob, you really did a good job in your mouth." Of course, I did that. I mean, that's a thrill for me. And what does the patient do? That's how you get big cases.
Yes.
Simple as that. That's how you get big cases. So if we look at what we really need to do in order to be able to get there, make sure you're addressing the want, not the what.
Mhm.
And look at how we addressed and really how Danielle addressed the want. Okay, do a full examination of every patient, every single patient, every single patient, every single patient. Have a defined methodology for that examination. So you're doing it the same way every single time. And use simple tools to educate your patient, like that pH paper. $10 roll of pH paper probably lasts you 6 months. Allow and train your assistant to participate with you in the treatment planning, and that may be the most important. Because if they're given the training, and then they're allowed to express themselves, and I know plenty of assistants who aren't. Better be quiet. Doctors in the office.
Yes.
Okay. Then you don't get this, and you don't get to see as many patients. Simple as that. So what about the IDS membership program? We want you to be members of the IDS. A lot of people are doing it, and they're doing it for a reason. Because the flow of dentistry is changing. The entire pattern of dentistry is changing. Referral patterns might be changing, but even if your referral patterns are exactly the same, there has to be a certain amount of ability for staff members to be able to communicate with doctors and staff members to communicate with each other, and particularly staff members to communicate with the patient. We spend an awful lot of time. In our library, we have tons of materials for staff training.
Right.
All done, nice little checklist. Saw the checklist for the examination. Don't you think we'd set up the same kind of checklist for in our library with 140 plus references? Of course.
The library is divided by easy to find categories, and one of them is for new patient examinations. And we just did a brand new whole module on the new patient examination from that phone call all the way to accepting the treatment plan. And it's a live module, live training of a patient coming in, and I'm the one that recorded it. I'm the one that did it, seating the patient, talking to the patient, collecting needs and want, doing the data collection, my discussions, showing them the models, getting all that information, briefing him coming in, doing the whole examination, me recapping it with the patient, getting what is it that you would like, which one of those options, what was it that you would like to do, getting them in that consultation room, getting them to accept and schedule. It goes step by step, and the modules are set up in a way that you can just say, hey Jane, I want you to watch these and tell me what you think. They're very easy to watch. We spend a lot of time making them easy to watch and easy to follow. You can use them at your staff meetings. You can do them for individual staff on improving their new patient phone calls, improving their communication and organization, doing these new patient examinations, gaining more acceptance, whatever it is that you're having the problem in your office. This library is packed with so many of these modules that you can do. And a lot of our members, they'll email us and say, hey, I'm having this problem with my staff. What should I do? I'll go to the library, I'll capture some links, say, here, have them watch this, do this at your next staff meetings, because we do offer the unlimited email support where you can say, hey, I'm having this problem, what should I do? Okay, go to the library, click this, go to this, and use all that. Oh, great. Thank you very much. So you're not going through there and searching. It's a wonderful tool for your staff.
Yeah. We just did one on Tuesday.
You're
already using.
That's right.
Yeah, new one. But you've all found out the fee's going up to $4.97 a month. Actually went up to $4.97 a month today, but here you are on the webinar. So of course we'll bring it back to $2.97. So you lock in the $2.97 with the unlimited email support, which you'll always use. It's time intensive, and so the fees are going up, but you can lock in the $2.97 a month rate if you sign up tonight. So locking in $297 a month, but it expires tonight. I know it sounds like high pressure selling. What the heck? It really isn't, because if you're not sure, you can join. When you join, you're going to join 60 days free
Right.
anyway. So you can try this all out for
Right.
60 days.
Email us, try us out, check out the library.
Yeah, just do everything, and you're locked into the $297 a month, but you don't start paying until month number 3. So you try us out in April, try us out in May, and then June, if you say it's not working, or the end of May say it's not working, just say it's not working, and that's it. You don't receive a bill. Okay, so lock it in, and all you do is go to directorofdentistry.com/IDS, and you'll see all the information there. Just click on it, join us, and I think you'll be very happy that you did. There's an awful lot that we can do without hiring a consultant. Yes, people hire us for consulting, and we do go into offices, or now it's a lot of Zoom meetings and things like that. We have people coming up here to be able to see what's going on in the office. We have one who's flying in from across the country with the staff, is coming in the middle of this month.
Yep.
So there's a lot that can be done with the consulting part. We're not talking about the consulting part tonight. This is a do-it-yourself type of program.
Correct.
So rather than pay consulting fees, and you all know what consulting fees are, then you can do it yourself. Some of you'll decide to hire us for consulting. That's fine. Some of our members have been with us for, well, it's almost 7 years now.
Yes.
They are doing it themselves, and they're doing just great. So you can choose, and you pick it how you want. And if there's a question, as Danielle said, you just email us, and we lead you in the right direction. Okay. So I don't know if there's anything else to say. Is there anything else to say?
No.
No.
Just try us out. Join. There's no commitment on it. Just do the free, and I guarantee that you'll find lots of gems in the library. For doing this, from me going to different offices and consulting offices for a while now, I'll tell you that all of our problems are the same. We all deal with the same barriers and struggles. I've yet gone to an office and like, well, that's a new one. It's never new. We've been there, we've done it. We're still a working, practicing, successful periodontal office. So I'm just sharing with you what works for us, and we're not going to show you and train it with you unless it's worked very well for us. So save your time, save your money, save your frustrations, and just let us help you get to that next level.
Good. Thank you for joining us. Happy Easter.
Yes.
Happy Passover for the remainder of Passover, or whatever you're celebrating. Hope it's all good for you. Thanks for joining us.
Thank you.